Starting out with the first, that is the specialty surgery. In the specialty surgery, the first topic is going to be the minimally invasive surgery. So inside the minimally invasive surgery, what are the advantages of minimally invasive surgery? Advantages are there is a smaller wound size, then there are decreased chances of wound infection, wound adhesions, bleeding, herniation, then improved mobility, decreased wound trauma, decreased heat loss, and it improves the visualization as well. What are the basic principles of laparoscopy or any minimally invasive surgery? The basic principles are given by this mnemonic, that is EVITROS. So EVITROS, I stands for insufflation, so insufflation by a gas. Then the V stands for visualization, inspection, triangulation, retraction of the tissues, operation, and a seal. Now talking about the first, that is creation of pneumoperitoneum. So when the pneumoperitoneum is created, we insufflate by using a carbon dioxide gas, or if carbon dioxide gas is not present, nitrous oxide can be used. Oxygen or air should not be used because they are combustible gases. They can create a blast during cautery. The pressure that is to be maintained is 10 to 14 mmHg, and the flow of the carbon dioxide should be 1 to 4 liters per minute. Now, effects of creating a pneumoperitoneum. What will happen to the heart rate and the BP? So initially, there will be a sinus bradycardia, which is the most common type of arrhythmia that will happen. Then there will be hypotension, and because of hypotension, there is a reflex tachycardia. Talking about the airway, so there will be increased airway resistance because of increased intrathoracic pressure, and so the COPD patients, they should be specially considered for this. While the anesthetist, he increases the positive end expiratory pressure. What will happen to the urine output? Obviously, it will decrease because of the pressure on the renal vessels, and intracranial tension will rise. Now, what are the methods of laparoscopy? So there is either blind technique or open technique. The blind technique, it is used by a needle that is called as a Veress needle. This Veress needle, you have to confirmation of this needle in peritoneum, which is done by injecting saline, and it does not aspirate, while also you will see that a drop of saline is getting sucked because of the negative pressure in the peritoneal cavity. Now, the most common site for Veress needle insertion is going to be infraumbilical, or otherwise palmar site can be done. Palmar site, it is located 3 cm below the left costal margin along the mid-clavicular line. Now talking about the next technique, that is open technique. In the open technique, this is also called as the Hassan's method. It is generally preferred in case of previous abdominal surgery or pregnant patients, so that extra care can be taken. Now there is something called trocar. Trocar is a device which facilitates the use of other devices, other laparoscopic devices. The first trocar is inserted blindly, while the other trocars are inserted with the help of video assistance. Now the trocar that is used in blind procedure is a sharp trocar, while that is used in the open procedure is the blunt trocar, and that is also called as the Hassan's trocar. Complications of trocar. So if a trocar is not properly inserted, or if too much force is applied, then in that particular case it can lead to injury to the bowel. What is the management during this condition? You don't have to remove the trocar, because the trocar is going to seal the perforation and it helps to locate the injury, so don't remove the trocar. Then the different laparoscopic instruments. The laparoscopic instruments, they have to be inserted in a triangular fashion so that they don't clash with one another. The different angles are used. So first is the azimuth angle, where 30-degree angulation is made, manipulation angle where 60-degree angle is made, and elevation is again a 60-degree angle from the horizontal. Then it has got a black coating. This black coating actually provides an insulation, because of which the other organs, they cannot get a shock. Complications: if there is a improper insulation over this device, then that can lead to capacitance coupling. So in capacitance coupling, the bowel can get burnt. So this is the very important complication. The limitations of this minimally invasive surgery are 3D vision. We cannot get a 3D vision, and tactile feedback is not possible. Similarly, the large specimens, they cannot be excised out. It is high cost, and we have to be reliable about the new technologies. The most common complication, however, is the carbon dioxide retention. Now, what happens during the carbon dioxide retention, and it is most commonly seen in laparoscopic cholecystectomy. Now, this carbon dioxide, it will remain under the right dome of the diaphragm, and this will lead to a referred shoulder tip pain to the right side. Then bleeding. If there is going to be a bleeding, then we have to suture on the either sides of the trocar and ligate the vessel, elongate the incision, or we can use a Foley's catheter, and this Foley's catheter can have a tamponading effect. The evolution of the laparoscopic surgeries. First, conventional laparoscopy, where the 3-port incision was made for laparoscopic instruments. Then there came a single incision laparoscopic surgery, where from a single incision all the three ports were present. The most common site was infraumbilical, and the disadvantages was the clashing of instruments happened and there were increased risk of herniation. Then hand port. In a hand port, what happened is there was 2 ports for the laparoscopic instruments and then was 1 port for the hand to go inside. This will increase the feel and tactile feedback to the patient, and also helps in better dissection. Now the next game is the nodes, that is natural orifice transluminal endoscopic surgery. The next nodes procedure is done through the natural orifices. So through the oral orifice the poem is done, that is peroral endoscopic myotomy. Peroral endoscopic myotomy is used for achalasia cardia. Then toga, that is transoral gastroplasty, that is done for bariatric surgery. Rose, pose, these procedures came. Then the V nodes is through the vagina. This is used for cystectomy or hysterectomy. Then rectum. In the rectum, this Tatame procedure came, that is transanal total mesorectal excision. So transanal total mesorectal excision, that is Tatame procedure. Then the robotic surgery. In the robotic surgery, disadvantage is that it has got a very higher learning curve. Advantages, however, it provides a 3D vision. Then it provides more degree of freedom, that is about 7 degrees of freedom is provided. Then scaling of movements can be done, and if the surgeon's hand is having tremors, then that can also be prevented during the surgery. And the original system of robotic surgery was given by Da Vinci. Next is the transplant surgery. So in the transplant surgery, the first thing is the classification for the dead donors. So classification for the dead donors is called as the Maastricht classification. So according to the Maastricht classification, there are class 5s. In the class 1, there is going to be the one that comes as a dead on arrival. Class 2, unsuccessful resuscitation. Class 3 is a cardiac. Class 3, 4 and 5 are cardiac arrest. Class 3 is anticipated cardiac arrest. Class 4 is cardiac arrest in dead donor, and class 5 is a cardiac arrest in the IPD patient. Now, inside this, the organs procured from the different patients are different. For example, in the class 1 patient, that is dead on arrival patient, the organs procured are the cornea and the heart walls, while in the unsuccessful resuscitation patient, we take it the heart walls, the kidney and the cornea, while from the cardiac arrest patients, we can take all the organs except the heart or the heart walls. Then the storage is done in the University of Wisconsin solution. The temperature is about 4 degrees Celsius, and the constituents are given by this mnemonic that is called as GAL. So G stands for glutathione, then the H stands for the hydroxyethyl starch, A stands for adenosine, another A stands for the allopurinol, and the L stands for lactobione or lactone solution. It is injected through the aorta and through the portal vein. The cold ischemia time, it is maximum for the kidney about 36 hours, and it is about 3 to 6 hours that is least for heart. Normothermic machine perfusion, it is done. The advantages for this is that because there is a normal temperature, it is the physiology of the organ is maintained, and early graft function upon placement. Talking about the individual transplant, the first is the renal transplant. Indications of renal transplant: most common cause in adults is diabetic nephropathy, and most common cause in children is going to be glomerulonephritis. The donor criteria is that a person who is more than 60 years of age and fit, more than 50 years of age, who either has a hypertension, a serum creatinine of 1 point more than 1.5, or a history of stroke can be used. Then there is a dual renal transplantation. Dual renal transplantation, where the two marginally normal kidneys they are used for transplantation, and they will provide a function of one normal kidney. Then investigations that are done in the donor are the RH compatibility, HLA compatibility, in that the DR compatibility is more important, ABO compatibility, then KFT, and the ultrasound of the kidney and urinary bladder. Which kidney is preferred and why? So in the donors, the left kidney is preferred because the left renal vein is larger than the right renal vein. Then it is considered to be a heterotropic renal transplant. It is considered to be a heterotropic renal transplant because it is placed inside a different site, that is iliac fossa. Now this particular table is very important, that is the site inside a live donor and dead donor, renal artery and renal vein. So in the vein, this particular mnemonic, that is VE, capital E. So according to this, in the renal vein, whether it's a live donor or end donor, it remains the same. End to side anastomosis is done, and it is and the renal vein of the donor, it is attached to the external iliac vein. The renal artery in a dead donor follows the same criteria. Here The renal artery of the donor is ligated to the external iliac artery of the recipient, while in live donor it's just opposite, that is end-to-end anastomosis is done and it is attached to the internal iliac artery. So the next is going to be, if serum creatinine levels are more than 10% from the baseline or more than 20 micromoles, then in that particular case the acute rejection it happens, and this is most commonly seen because of calcineurin inhibitor toxicity that are given during the transplant surgeries. The complications, the most common complication is going to be the vascular complications that includes the renal vein thrombosis and renal artery stenosis. The investigation is CT angiography for both. Management for renal vein thrombosis is going to be anticoagulants, and for renal artery stenosis it is going to be balloon dilatation. Then rejection. So rejection can be hyperacute, acute and chronic rejection. Hyperacute rejection is a type 2 hypersensitivity reaction. It happens on the operation table itself, and there is going to be a dusky kidney having coagulative necrosis or fibrinoid necrosis. Then acute rejection is going to be tubulitis or endothelitis. Chronic rejection is going to be type 4 hypersensitivity reaction. It is given by a pneumonia, that is COTI. So G stands for glomerular basement membrane duplication, O stands for obliteration of the vessels, T stands for tubular atrophy, and I stands for the interstitial fibrosis. Then infections, the most common oral infection is viral infection. Bacterial infection, it happens usually within the first month. Then malignancy, the most common malignancy is the skin cancer, and the most common type 4 here is going to be squamous cell carcinoma. Then PTLD, that is post-transplant lymphoproliferative disorder. In post-transplant lymphoproliferative disorder, there is going to be B cell symptoms that happen, and it is associated with Epstein-Barr virus. Then there is a BAMS classification. It helps us to know about rejection. Now there are different types of biopsies. First is the needle biopsy, that is generally done for solid organs like liver and kidney. Then subendocardial biopsy from the jugular vein, it is done for cardiac, and endoscopic mucosal, it is done for bowel. Now the pancreatic transplant, generally in diabetic nephropathy, both kidney as well as pancreatic transplant is done. Initially there is a bladder anastomosis. 3 to 4 years after, there is an enteric anastomosis. The next important is the liver transplant. The liver transplant is the most common cause in adults is going to be cirrhosis, and the cause for cirrhosis is going to be non-alcoholic steatohepatitis or metabolic dysfunction associated steatohepatitis. In children, it is going to be extrahepatic biliary atresia. HLA matching is not required, so there is no hyperactive rejection in case of liver transplant. Now there is a Milan's criteria. It is used for hepatocellular carcinoma. According to Milan's criteria, there are 3 important points. The first important point is there should not be any metastasis, a single tumor of less than 5 cm, or 1 to 3 tumors each of less than 3 cm. Then King's criteria, it is used for acute hepatic failure. It can be either because of paracetamol toxicity or non-acetaminophen induced. Then auxiliary liver transplant, it is also called as piggyback liver transplant, and this is done in case of fulminant hepatic failure wherein the deceased liver it is not removed. Then domino transplant, wherein a person with systemic liver disease, that liver is transplanted into another person of the same systemic disease, for example in HIV or amyloidosis. Sequence of anastomosis is very important, and a mnemonic given is I love pervaginal examination, she is happy, I feel bad. So I stands for inferior vena cava. So first suprahepatic inferior vena cava, and then the infrahepatic IVC, then the portal vein, then the hepatic artery, and then next is the common bile duct. Complication, rejection, there is no hyperacute rejection as there is no HLA matching required over here. It can be either acute or chronic, out of which the chronic is most common, and histopathological examination we see a vanishing duct syndrome. Then the most common vascular complication is going to be hepatic artery thrombosis, and recurrence is another complication. Now the heart transplant, the sequence of anastomosis is again very important. It is given by this mnemonic LRRL, that is left atrium, right atrium. Then the R stands for the right side pulmonary artery, and the left side, that is aorta. Then the type of biopsy that is done is the subendocardial biopsy from the jugular vein. The lung transplant, the sequence of anastomosis is VBA, that is pulmonary vein, then bronchi, and then the pulmonary artery. Who is considered to be a donor for lung transplant? A person having a smoking history of less than 20 years or arterial oxygen tension of more than 300 mmHg. Indications for lung transplant are cystic fibrosis, interstitial lung disease, COPD or emphysema, or it can be pulmonary hypertension. Then next is the small bowel transplant. The indication for small bowel transplant is going to be having a short bowel syndrome, wherein long-term parenteral nutrition is required. The parts that are transplanted are usually the jejunum and ileum, And the challenges are actually there is going to be a lot of lymphoid tissue over here, and so there is increased risk of rejection and graft versus host reaction. Next is the graft versus host disease. So graft versus host disease is seen in immunocompromised patients. And what are the transplants wherein it is commonly seen? It is seen in small bowel transplant and it is seen in bone marrow transplant. Now the graft versus host disease relates to manifestations that is given by this mnemonic SIL. So it affects the skin, that will lead to rashes. Then it will affect the intestine, that will lead to diarrhea, protein losing enteropathy, edema, and will affect the liver, that will lead to liver dysfunction or cirrhosis in long term. Then the next is going to be the plastic surgery. So in the plastic surgery, the first is we have to talk about the types of graft. So there is autograft. Autograft means from the same patient. Isograft from the identical twins. Then there is allograft from the same species, and then xenograft from the different species, right? Then what's the difference between the graft and a flap? So graft is the one which does not have its own blood supply. It takes the blood supply from the host site, while a flap is the one which has its independent blood supply. Now there are two types of grafts: split thickness skin graft and full thickness skin graft. Split thickness skin graft, it is also called as Thiersch graft, while the full thickness skin graft is also called as whole face graft. Now the donor side for split thickness skin graft is anterolateral side of the thigh or the buttocks. For full thickness skin graft is going to be the postauricular region or into the supraclavicular fossa. Morbidity is more with full thickness skin graft. Reusability is more with split thickness skin graft. Then sutures are required in full thickness. Composition: split thickness skin graft consists of the epidermis and part of dermis, while epidermis and complete dermis is present in full thickness skin graft. Primary contracture is the contracture at the donor site and is directly proportional to the amount of dermis. So primary contracture is more in the full thickness skin graft. Secondary contracture happens at the level of recipient, and this is more in the split thickness skin graft. Survival chances or take-up chances are more for split thickness skin graft. In case of trauma, the full thickness skin graft is more resistant, and cosmetically full thickness skin graft is better because split thickness skin graft it undergoes blackening. Then meshing is done in split thickness skin graft. The significance is that it prevents the seroma formation and increases the surface area for survival or take-up. Then the graft survival for 1 to 2 days, it depends upon imbibition, that is diffusion of the nutrients. Then inoculation for 2 to 4 days, and neovascularization it develops from more than 4 days. Now very important, in inoculation the buds are formed from the donor side and not from the recipient side. The graft failure, the most common cause of the graft failure is going to be seroma formation. Because of seroma formation, it lifts up the graft, and because of which the proper imbibition cannot happen. Then apart from that, infection can happen. Group B streptococcus infection, then staphylococcus infection are common. Then movement over the graft site, that is shearing force if it is applied, then also it leads to displacement of the graft, and a poor recipient bed. So basically the recipient bed, it should be cleared off from any slow material. For example, if there is a shower of, or if there is going to be any um, granulation tissue, then it should be first cleared off, and then the graft should be placed. The flap types. So flap is the one having an independent blood supply. So the types of flap, the first is a random flap. Random flap, it is based on the dermal vessels or the dermal plexus. The length to breadth ratio ideally should be 3:1. If more length is taken, then that will lead to necrosis of the flap. Uses of this, they are generally used in case of post-burn contractures or in cleft palate repair. Then there are different types: VY-plasty, Z-plasty. In the Z-plasty, remember 60-degree Z-plasty, it has got a maximum elongation. Then rhomboid flaps, R का B बना देता, so that is used in basal cell carcinoma. Then bilobed and bipedical flap. Bilobe का O important है, that is used for nose reconstruction in basal cell carcinoma, and bipedical का E, that is used for eyelid reconstruction in basal cell carcinoma. Axial flaps are based on the blood vessels, and the classification that is used, that is called as the Mathis and Nahai classification. Now class 5 out of which is very important, which has got one dominant pedicle and other minor pedicles. Now they are used in head and neck surgeries. Deltopectoral flap, which is based on internal mammary artery, and pectoralis major myocutaneous flap, which is the most commonly used flap, but is based on thoracoacromial artery. Abbe-Slander flap, the PMMC flap is used for oral cancers. Abbe-Slander flap is used for the tip of the tongue or the angle of mouth cancers. It is based on the labial vessels. Then breast, in the breast there is a latissimus dorsi flap. Then there is a tram flap versus TF flap. Tram, that is transverse rectus abdominis flap, and DF, that is deep inferior epigastric perforator flap. The tissue included in tram flap is the skin, subcutaneous tissue, fat as well as muscles, while in DF flap it is skin, subcutaneous tissue and fat, so that is muscles are not involved. Blood supply, the blood supply of the triumph flap is superior and inferior epigastric artery, out of which if it is only inferior epigastric artery, then it is a free flap, that is dive flap. Dive flap, it is supplied by deep inferior epigastric perforated artery and is a type of free flap only. Incisional hernia chances are more with the triumph flap because muscle is involved, and better overall is the dive flap. Now the next is the free flap. Free flap is the one that can be taken from one side and can be lodged into another side. So in the head and neck surgery, generally the radial artery forearm flap is used, which is based on the radial artery, and for that first we have to do a test, that is modified Allen's test. Then free fibular flap is used for mandibular reconstruction in edentulous mandible. Then composite flap having one or two components, that includes the triumph flap, dive flap, PMMC flap, conjoined and chimeric flap. So these are the different types of flaps. After the next, we have to assess the flap failure. So flap failure monitoring is done by looking at the blood supply. So we use a handheld Doppler or a pinpoint pricks can be made to see whether fresh bleeding appears or not. Then the next is the skin grafting. So we should understand the skin grafting. So in the skin grafting, so it's actually the skin banking. So in the skin banking, the skin grafts, the split thickness skin grafts, only STHG, split thickness skin grafts, they are stored for 2 to 3 weeks with the help of liquid nitrogen or carbon dioxide at 4 degrees Celsius. Now the next is the bed source. And the bed source or the pressure source, the pressure that is required for the bed source or the pressure source is 30 mmHg, the same as that of the compartment pressure. Now the most common site that is given by this mnemonic, I solve JTs and I feel happy. So I stands for ischium is the most common site, followed by greater trochanter, sacrum, and H, that is going to be heel. So this is the mnemonic. Then prophylactically you can frequently change the position of the patient. In a wheelchair patient, for every 10 minutes you have to lift a patient for 10 seconds, and in case of bedbound patient, every 2 hours the patient should be motivated to change the position. Now grading is done as grade 1, 2, 3, 4. Grade 1 is non-launching erythema, grade 2 is partial thickness skin loss, grade 3 is full thickness skin loss, grade 4 is full thickness skin loss along with subcutaneous tissue loss. In grade 1, conservative management is done offloading or offsite spray. Offloading is using air mattress or water mattress, and offsite spray, it actually prevents the further progression. Then the partial thickness skin loss wherein and full thickness skin loss wherein debridement is done, and after which a vac is applied, that is vacuum assisted closure, where a pressure of minus 125 mmHg is used. It leads to increase in vascularity. So one of the side effects of this is, most common complication is going to be bleeding. Then what are the indications for using a vac? The indications of using a vac are if there is a chronic non-healing ulcer like a venous ulcer, arterial ulcer, diabetic ulcer, or burn wounds in bed sores, this is used. Contraindications is that if there is a Ishar, right, then the first Ischarotomy is done and then vac is applied. Or it is also contraindicated if there is going to be osteomyelitis in case of diabetic ulcer. Then in class 4, where there is a subcutaneous tissue loss, there is a debridement and followed by a flap closure, and a flap uses the tensor fascial lateral TFL flap. Wound healing. The process of wound healing that is given by this mnemonic, that is Hipparcher. So first H stands for hemostasis, then I stands for inflammation phase, which lasts for about 4 days. Then another P stands for the proliferative phase, where the collagen tissues they are going to proliferate, and then the R stands for the remodeling phase. In the proliferative phase, the type 3 collagen is seen. In remodeling phase, the type 1 collagen, it increases. The final ratio of type 1:3 is 4:1. Now the factors affecting the wound healing. The factors affecting the wound healing are local and systemic. So the local factors is radiation, there is infection, trauma. In the systemic factors, there can be anemia, then zinc deficiency or calcium deficiency, immunocompromised patients, vitamin C deficiency, steroids, right? Then the wound strength. At the end of 1 week, the wound strength is around 10%. At the end of 3 months, it is around 70%. Never regains the original. Then healing by primary intention is the secondary intention. Primary intention, it is because of clean cut wound or surgical wound. Here there is minimal contracture and there is going to be minimal scar that is formed, right? Then and minimal granulation tissue as well. In secondary intention, there is a wound contracture, that is a bad scar formation, and there is a lot of granulation tissue formation. Then what are the complications? Keloid and hypertrophic scar. What's the difference? The first is the site. So the most common site for keloid is going to be the sternum, then the shoulder tip, ear lobes. In the hypertrophic scar, it is generally found on the extensor surfaces. Predilection keloids are generally found in the African Americans, while hypertrophic scar, it is more commonly seen in case of children. Then the growth. The growth of the keloid is haphazard. I mean, it goes beyond the margin. In hypertrophic scar, it remains within the margin. Relieving factors: if pressure is applied and with time, the hypertrophic scar it relieves. But however, keloid does not relieve. The management for keloid is intralesional triamcinolone. For hypertrophic scar, it is silicone pads. Then cleft lip and cleft palate, very important topic. Incidence is 1 in 600, more common in males. Most common defect is both cleft lip and palate combined defect. Then the syndrome that is associated with this is called as the Pierre-Robin syndrome. In Pierre-Robin syndrome, there is a retrognathia, there is a uh, posterior falling of the tongue, and associated with cleft palate. Now the documentation is done in Lehsal staging. L stands for lips on one side, A stands for alveoli on the one side, then H stands for the hard palate, S stands for soft palate, A stands for alveoli on the other side, and L stands for the lip on the other side. Now it can be in small letters or it can be in capital digits. So in small digits, it is going to be a partial defect, and capital digits it can be a complete defect. What are the clinical features? Speech impairment can happen, feeding difficulties, and middle ear infections. So this defect should be done without before the speech development. Management: cleft lip. Cleft lip is managed by around 3 to 6 months, and the surgical repair that is done is called as the Millard's repair. Then the cleft palate, it consists of soft palate and hard palate. Soft palate should be managed 3 to 6 months, while the hard palate should be managed by around 12 to 15 months because it takes time for the bone to develop. Then the types are unipedicle or bipedicle. In the unipedicle repair, you have the viviplasty or Wardell-Kilner's plasty, and in bipedicle there is a von Langenbeck repair. Complications are bleeding, then infection, then misalignment that will lead to appearance that is called as cupid bow appearance of the upper lip, and velopharyngeal insufficiency. So this is all about the plastic surgery. Now moving on to the next, that is the basics of trauma. In the basics of trauma, the first thing is the information collected. Information collected from the driver or the responder is missed. That is the mechanism and the injuries, signs and symptoms, and the treatment that is given. From the patient, ample information is collected. So the mnemonic is ample. A stands for the allergies, M stands for medical condition, P stands for past history, L stands for the last meal, so that it helps with intubation, and E stands for event leading to trauma. Then transportation. The transportation, the patient is done in supine position on a hardboard. The head, thorax, abdomen, and the pelvic region. Basically, head, thorax, and pelvic region it is strapped. Then the prone position, it helps to decrease the risk of aspiration. Lateral position is never preferred because there are chances of cervical spine injuries. Then there is a timeline concept. In the timeline concept, we find that there is a trimodal distribution of mortality. The mortality being the highest in the immediate time after the mishap, then within 1 hour, and then day to weeks after it. The golden hour is the first 1 hour where we manage the patient of trauma. Immediate. The immediate is the maximum head injury. Is going to be the massive head injury, which has got the maximum risk of mortality. Then within 1 hour, it can be related to the airway, breathing, and circulation. In the airway, it can be the tracheobronchial injury or airway obstruction. Then in the B, that is breathing, it can be tension pneumothorax, open pneumothorax, or cardiocirculatory arrest. And in the type C, it can be circulation related, that is cardiac tamponade and pneumothorax. Days to weeks after, it can be sepsis or delayed head injury. Now there is a concept called triage. So the triage, there are different colors: red, yellow, green, blue, black. What are the category? Red category is called as the emergency. The examples of emergency are going to be a massive head injury or massive hemorrhage patient where they have to be treated within 1 hour, or within 1 hour their mortality chances are high. Then yellow is urgent, where isolated limb fractures are taken. Then green is going to be delayed, and in this they are ambulatory patients which require first aid. They may have contusion, laceration injuries. Then blue are the moribund patients, for example more than 70% of third degree burns or massive head injury, more than 90% hemorrhage, and if such things are happened, then these are the moribund patients. And the black are the dead patients. The category of blue is called expectant. Then the next, is going to be ATLS versus BLS protocol. So in the BLS protocol, the first is going to be CAB, that is compression, airway and breathing. Within the ATLS protocol, it is ABCD, that is airway, breathing, circulation and disability. Primary survey, it includes this ABCD criteria. In secondary survey, we do a detailed survey, and tertiary survey, it is post extubation. So in the primary survey, the first thing is going to be cervical spine stability. So for the cervical spine stability, we have this nexus criteria. If there is a neurodeficit, E stands for ethanol, that is alcohol intoxication. X stands for extremely distressing image. Then the U stands for unable to tell the history, that is the patient is disoriented. And S stands for spinal tenderness. If any of this is present, then you have to go for imaging, that is X-ray, and you have to give a Philadelphia collar, that is called as a cervical collar, to the patient. If all the signs are negative, then in that particular case, there is no need of imaging. Airway, the easiest assessment of airway is to allow the patient to speak, so that we come to know whether the airway is patent or not. Compromised airway signs are the GCS less than 8. Then if the patient is in confused state, unable to speak, or in coma. Management, you have to do the intratracheal intubation. If it is possible, most common is going to be oral route. Nasotracheal route is used if not oral possible, but however the contraindication for nasotracheal route is base of skull fracture. If the endotracheal tube is not possible, then cricothyroidectomy. If that is also not possible, then tracheostomy is done. Then breathing. Now when I talk about the breathing, that here we need to assess the chest X-ray in the AP view, and then the EFAST technique, that is extended focused assessment sonography in trauma. Then circulation. The circulation, two 18 gauge IV lines are used. 1 liter of fluid is given. If the IV access is not made, then in that particular case, emergency intervention in the form of intraosseous infusion can be done, or venous cut down where the great saphenous vein is used. The definitive management is putting central line. Then next, there is going to be crash to trial. Crash to trial is used to assess the use of 1 gram of tranexamic acid, how it affects the mortality. And the disability is given by the GCS Glasgow Coma Scale. Mild head injury means a score of 13 to 15. Moderate injury, that is 9, 10, 11 and 12, and severe injury, that is a score of less than or equal to 8. In the Glasgow Coma Scale, it consists of EVN, that is eye response, verbal response and motor response. So first is the eye opening. The lowest value can be 3, that is seen in coma patients. So 1, no response; 2, response to painful stimuli; 3, response to verbal stimuli; and the 4th is spontaneous opening of the eyes. Then the verbal response. The verbal response, the first is no response, then second, there is incomprehensible words; third, inappropriate words; then fourth is confused, and fifth is oriented to time, place and person. So second is actually sounds. Then the motor response. 1 is no response, second is decerebrate rigidity, that is extension; the third is decorticate rigidity, that is flexion; the fourth is the patient does a flexion withdrawal from the painful stimuli. Then fifth is he is able to localize the site of painful stimuli by using the other limb, and sixth is he obeys all the commands. Along with the GCS score, the pupillary reactivity score is also added. Then log roll maneuver, it is done for looking at the back of the patient, examining the back. The minimum people that are required for this are 4. If the limb fracture is present and minimum 5 people are involved, then pelvic fractures, if they are present, in that particular case, you should not perform this log roll maneuver, otherwise dislodgement of clot can happen. In case of penetrating abdominal trauma, this is done because we want to see if the exit wound is present or not. Then there are different scores that are used. Injury severity score. The next is the revised trauma score, that is RTS. The components of RTS are respiratory rate, then the T का G बना लें, that is the Glasgow Coma score, and S stands for systolic BP. Then trauma risk and injury severity score, that is stress. It consists of REMA. The mnemonic is REMA. So R stands for reverse trauma score, I stands for injury severity score, that is ISS. Then M stands for the mechanism of injury, and A stands for the age of patient. Now in the mangled extremity severity score, that is MES score, the mnemonic is SITA, where S stands for the shock group, I stands for ischemic group, T stands for the type of injury, and A stands for the age group. If the score is less than or equal to 6, then that limb is salvageable. If the score is more than or equal to 7, then in that particular case it is amputation is required. Metabolic response is given by Abed flow. So in the F phase, there is within 24 hours, it can be decreased via good resuscitation. So the F phase is the one that can be changed by good resuscitation. It can be decreased. While in flow phase, it can be a catabolic phase or anabolic phase. Catabolic phase is for 3 to 10 days, and anabolic phase is from 10 days to 60 days. In the ape phase, it maintains the blood volume. In the catabolic phase, it maintains the energy, while in anabolic phase, it leads to replacement of the lost tissue. What are the hormones involved? In the ape phase, all the stress hormones like the cortisol, catecholamines, they are involved. While in the catabolic phase, the insulin, glucagon, some amount of cortisol and catecholamines are also present. While in the anabolic phase, it's mostly the growth hormone and the insulin like growth factor involved. The physiology is in the ape phase, the BMR, oxygen consumption, temperature, it decreases. What increases is cardiac output, right? Then the heart rate and acute phase reactants. Now in catabolic phase, there is increase in BMR, temperature, oxygen consumption. Very important. In catabolic phase, there is a negative nitrogen balance, and because of which protein consumption is required during this phase. While in the anabolic phase, there is a positive nitrogen balance. The anabolic phase is also called as the Murray phase. So these are the basics of trauma. Now the next is going to be the abdominal trauma. So in the abdominal trauma, the most common injured overall is going to be the spleen. In the blunt trauma also it is going to be the spleen. In the penetrating trauma it is going to be the liver. In the gunshot wounds it is going to be the intestine, and in the seatbelt syndrome it is going to be the mesentery. In decelerating injury it is the hepatoduodenal flexion, and in the children it is again going to be the spleen. Now let's talk about the blunt trauma. Either the patient can be hemodynamically stable or unstable. Now, what is the first investigation and the investigation of choice in such patients? The first investigation for both of them is going to be the FAST. While investigation of choice in stable patient is CECT. While in unstable patient remains to be the FAST. We cannot do a contrast, put a contrast in these patients. The management is midline laparotomy. Then the FAST, that is the focused assessment sonogram in trauma patients. So here the 4 essential sites that is checked: the epigastrium to look for cardiac tamponade, then left upper quadrant for collection around the spleen, right upper quadrant for collection around the liver, and then the suprapubic part for any pelvic collection. Now extended FAST technique, where the right anterior chest and the left anterior chest are also assessed. The disadvantages of FAST is that minimum 100 ml of blood should be present. It is unreliable in penetrating trauma and also unreliable in retroperitoneal trauma. Then workup of this patient, if it's going to be a case of blunt trauma, abdominal examination is done. If on FAST, if peritonitis is seen or if the patient is unstable, then in that particular case we have to go for exploratory laparotomy. Then in FAST, if the peritonitis is not seen and the patient is stable, then you have to give contrast enhanced CT. And if the contrast enhanced CT, if the hollow viscous injury is seen, if it is present, then you have to again go for exploratory laparotomy in these patients. If it is no, then assess for solid organ injury. If solid organ injury is also not present, then manage other injuries. If it is present, then go look for pseudoaneurysm or arterial flush. If it is present, yes, then in that particular case, you have to go for midline laparotomy. If it is no, then manage it conservatively. Now, what about a penetrating trauma patient? In the penetrating trauma patient, some sharp objects like the knife can be used. Very important is that you should not remove these objects, because these objects act as a seal for the perforation. If there is a superficial perforation that is above the level of peritoneum, then in that particular case, CCT and local examination is done. Manage the patient conservatively. If it breaches the peritoneum, in that particular case, look for the signs. So, what are the signs of breaching? Guarding, rigidity, right? Apart from guarding rigidity, the oventum, it can be seen coming out, bile stains can be seen, and management for this patient is going to be laparotomy. Then if the FAST scan is not presented, in that particular case diagnostic peritoneal lavage is done. It is done after gastric decompression by the Rice tube and bladder decompression done by the Foley's catheter. If more than 10 cc of blood is aspirated, then you have to go for midline aspiratomy. If no such aspiration is seen, then in that case inject 1 liter of ringer lactate solution and re-aspirate. If on the re-aspiration, if the RBCs are more than 1 lakh, WBC more than 500, fecal contents are present and serum amylase levels are more than 175, then in that case again you have to go for midline laparotomy. Then the next, splenic trauma, that is now individual organ trauma. It is generally seen in 9 to 11 ribs, and generally the spleen, it lies along the axis of the 10th rib. Now Kerr sign is also present. What do you mean by Kerr sign? So basically Kerr sign means that whenever there is a splenic trauma, then there is, on raising the left lower limb, the blood accumulates beneath the left arm of the diaphragm, and that will actually lead to referred pain to the left shoulder tip. The referred pain to the right shoulder tip is actually seen in case of pneumoperitoneum, right, in the minimal invasive surgery. Now, the grading of splenic trauma, it is based on subcapsular hematoma, parenchymal hematoma, and laceration. So in the grade 1, the subcapsular hematoma is less than 10%, laceration is less than 1 centimeter. Now in the grade 2, the subcapsular hematoma is 10 to 50%, laceration is 1 to 3 centimeter, and parenchymal hematoma is less than 5 centimeter. Then in grade 3, it is more than 50%, subcapsular parenchymal hematoma is more than 5 centimeter, and laceration is more than 3 centimeter. In grade 4, it is actually involving the perihilar vessels, and it is confined within the capsule. In grade 5, it is going to be a shattered spleen. The investigation of choice for grade 1 and 2, because it's stable patient CCT, investigation of choice for grade 4 and 5 remains to be the first. The first investigation for both is first. Active bleeding is present and there is an increased arterial blush on CCT. If vascular injury is present, then there is a decreased arterial blush. Now management, if it's a grade 1 and 2 patient, and so it's managed conservatively, but if the grade is increasing or the arterial blush is seen on CCT, then we have to go for angioembolization and splenography. It is the bits of spleen, they are basically preserved. Then in the grade 3, if it is a stable patient, manage it like grade 1 and 2. If it is a grade 3 unstable patient, manage it like grade 4 and 5. In grade 4 and 5, go for surgery. The surgery is called as the splenectomy. Now complications of splenectomy, as first is the hemorrhage, then second is the fistula. Actually, the tail of the pancreas, it lies close to the splenic hilum, and because of which fistula, pancreosplenetic fistula can happen. Then the next is hematological complications. The first is transient. So some transient changes are seen for 2 weeks. They include rise in all the blood lines. For example, the platelets can go more than 10 lakh. For that, prophylactic aspirin is given, RBC is increased, WBC is increased, everything increases. But the permanent hematological changes include the Howell Jolly bodies, Cabot rings, hypersegmented neutrophils, then basophilic stippling. So these are the permanent changes that remain. The most common complication, however, is going to be left lower lobe collapse. So there is a left lower lobe atelectasis or left lower lobe pneumonia, which is the most common complication post splenectomy. Then opportunistic post splenectomy infections, that is OPSI. In that, the bacterial infections which are seen, they are more common in the first 2 years, that are pneumococcus, which is the most common, then meningococcus and Haemophilus influenza B. Mortality, it is more in hemat conditions than in trauma conditions. Why? Because in trauma conditions, some placental bits can be retained and they can perform their function. Then vaccination for pneumococcus and meningococcus, every 5 years vaccine is taken. For Haemophilus influenza B, every 10 years vaccine is taken. And in case of influenza, viral influenza, you have to take it every year. The timing of vaccination in elective splenectomy, it is 2 weeks before, and for emergency, it is post-operative day 1 or 2. Then in liver trauma, again, it is based on subcapsular hematoma, parenchymal hematoma, and laceration. So subcapsular hematoma is less than 10%, parenchymal and laceration is less than 1 centimeter. And 2, the subcapsular hematoma is 10 to 50%, parenchymal hematoma is less than 10 centimeter. Here it is 10, and in spleen it is 5. Remember, liver is greater than spleen, so here the cutoff is 10. Laceration again 1 to 3 centimeter, here more than 3 centimeter. In grade 3, more than 50% subcapsular hematoma in grade 3, and more than 10 centimeter parenchymal hematoma in grade 3. In grade 4 and 5, here they are based on hepatic lobe dysfunction. So the 25 to 75% of the hepatic lobe is dysfunction, then that is grade 4, and if more than 75% is present, then that is grade 5. Now the next is, if it is grade 1, 2 or 3 stable, then you have to manage it conservatively, or if there is a grade up that is seen, then go for surgery. Similarly, in grade 4, 5 and 3 unstable, directly go for surgery. Now the surgery is the first maneuver, that is called as the Pringles maneuver. So this Pringles maneuver is the maneuver where the hepatic pedicle, which consists of the hepatoduodenal ligament, it is compressed for 15 to 20 minutes at the foramen of Winlow. Now what are the structures? The structures visible, they are given by the old mnemonic that we see in the liver transplant. That is, I performed per vaginal examinations. She was happy, I was feeling bad. So here remove the eye, that is the IVC part, remaining everything, that is portal vein, hepatic artery and common bile duct. These are the structures of the hepatoduodenal ligament. Now depending on, here we can look for the source of bleeding. If the bleeding stops after the Pringles maneuver, then it is mostly because of portal vein or hepatic artery. If the bleeding still persists, then that is because of hepatic vein. And then the packing is done. This packing, it provides a tamponade effector, because of which the bleeding is stopped. Complications can be bleeding, Then the bile leak. The bile leak happens from minor radicals. They have to ligate each radical. It happens over because of common bile duct or any major ducts. Then repair over the T tube is done. Then in abscess, then the strictures can be formed in the CBD, and vascular damage to the portal vein. In that particular condition, we have to repair it with the help of Prolene suture. Then mesenteric injury, it can be longitudinal or transverse. Remember, in longitudinal injuries, the vascular component or the vascular injury is not more, while in transverse injury, the vascular break is more. The management for longitudinal injury is going to be repairing of the tear, while in transverse it is going to be resection and anastomosis. For duodenum perforation, the management is omental patch repair. For pancreatic, the most important prognostic factor for pancreatic injury is going to be the main pancreatic duct. If there is a damage to the main pancreatic duct, if the body and the tail of the duct is damaged, then go for distal pancreatectomy. If the head of the pancreas is damaged, in that particular condition, go for Baker's procedure. In the Baker's procedure, you have to do a duodenal preservation. Only the pancreatic head is removed. In colorectal injury, generally colostomy or diverting colon operations are done, and the procedure is called as the Hartmann's procedure. In rectal, early total care should be done within 36 hours. Damage control surgery. The terrible triad of the damage control surgery, it includes the hypothermia, acidosis, and coagulopathy. There are phases. So phase 0 is identification of patient. Phase 1 is going to be laparotomy. Then in that laparotomy, we are going to look at the physiology. Then step 2 is correction of the physiology of the patient. So the correction of physiology of the patient. Then the step 3 is going to be correcting the anatomy by re-exploratory laparotomy. And the next is going to be abdominal compartment syndrome. So causes of abdominal compartment syndrome, they are going to be massive burns, massive ascites, and bowel obstruction. The pressure is measured by the bladder pressure. Actually, the bladder pressure is indicative of abdominal pressure. It is said to be intra-abdominal hypertension when the intra-abdominal pressure is more than 12 mmHg, and it is more than 20 mmHg, and we call it as the abdominal compartment syndrome. What will happen in abdominal compartment syndrome? There is a rise of intrathoracic pressure, the urine output will decrease, SBP will decrease, cardiac output will decrease, venous return will decrease, urine output will decrease, and intracranial tension will increase. Then retroperitoneal trauma is divided into 3 zones, zone 1, 2 and 3. Zone 1 is associated with maximum mortality, zone 3 is most common. In zone 1, what are the structures? It can consist of the aorta, the IVC and the pancreas, head of pancreas. Investigation that is done is going to be the angiogram. Investigation that is angiogram, it is done in unstable patients associated with maximum mortality. Then zone 2, it consists of the kidney, then the ureter and the renal blood vessels. The investigation that is done is single shot IV urogram in unstable patients. In stable patients, we can go for CECT. And in zone 3, which is the most commonly affected, the structures affected are the pelvic structures. Okay, so this is going to be about the abdominal trauma. So the next is going to be the thoracic trauma. So in the thoracic trauma module, the most common cause of death following a blunt trauma, it is going to be tracheobronchial injury, while the most common cause of death following penetrating trauma is going to be hemothorax secondary to pulmonary laceration. Investigation and chest X-ray should be done in the AP view and the extended fast technique, where right anterior and the left anterior chest region is seen. Now when I talk about chest X-ray, these horizontal structures, they are going to be the posterior ribs, while these shadow looking oblique and slanted structures, these are nothing but anterior ribs. Then the rib fracture. Rib fracture is the most common type of thoracic trauma. The most common rib fracture are the first rib and the 10th to 12th, that is the floating ribs. The first rib is associated with brachial plexus injury, subclavian vessels, or it is associated with an apex of lung. While the 10 to 12, that is floating rib, they are associated with left side is associated with splenic trauma and right side is associated with the liver injury. Now, however, the underlying organ damage, they are generally found in children because their ribs are pliable. Management is adequate analgesia. You don't have to do strapping of the thorax region. Then the flail chest. The definition of flail chest is very important. When more than or equal to 2 consecutive ribs at more than or equal to 2 locations, they are getting damaged. More than or equal to 2 consecutive ribs at more than or equal to 2 places are getting affected, and that is flail chest. The complications of the flail chest are, it can lead to underlying pulmonary contusion, which is the leading cause of death, and the next complication is paradoxical chest movements, which is a very important hint that is given in the question. Investigation choices, obviously the chest X-ray. Management, Adequate analgesia is given, thoracic epidural analgesia. But if the partial pressure of oxygen is less than 60 mmHg and respiratory rate is more than 20, that is somewhere the respiratory distress is seen, the intermittent positive pressure ventilation is given. If still the patient is not improving, then surgical fixation is done. Pneumothorax. Now, what are the types of pneumothorax? There are two types of pneumothorax. The first is going to be simple pneumothorax and the other is going to be tension pneumothorax. Etiology of tension pneumothorax. Etiology of the tension pneumothorax is tracheobronchial injury, then large pulmonary laceration, and then a penetrating wound. The pathophysiology is that when a penetrating wound is present, that is a stab injury, then this wound, it acts as a one-way wall. Because of the unidirectional or the one-way wall, there is a collapse of the ipsilateral lung, while there is expansion of the contralateral lung, and also the trachea is shifted to the opposite side. Then the clinical features are, it gives a very basic triad of tachycardia, tachypnea, and fall in the SPP, that is hypotension. So this is seen in tension pneumothorax, cardiac tamponade, as well as pneumothorax. While in simple pneumothorax, the hemodynamic status is stable. Then JVP is raised in tension pneumothorax and cardiac tamponade. In these two cases, it is normal. Breath sounds are absent in tension pneumothorax. In cardiac tamponade, it is normal. In hemothorax, as a simple pneumothorax, the breath sounds are again absent. Percussion note over here, it's hyper resonant. In cardiac tamponade, it is normal. Then in hemothorax, it is dull note, and simple pneumothorax, again it is hyper resonant. Then the cardiac sounds, they are normal in all other conditions except in cardiac tamponade, where it is muffled. So these are the basic chart of comparison between all these four conditions. The investigations: chest X-ray in the AP view, and in the extended fast, the M mode, a specific sign is seen, that is called as the loss of barcode sign, loss of seashore sign, or loss of stratosphere sign. Management: in emergency conditions, needle thoracocentesis is done. In adults, it is done along the fifth intercostal space in the mid axillary line, while in the children, it is done in the second intercostal space along the mid clavicular line. Definitive management: the definitive management is going to be tube thoracocentesis, and if it is, and when the open wound is seen in penetrating trauma, then a three-sided occlusal dressing is done. Then hemothorax is the where the accumulation of the blood, it happens because of the injury to the intercostal muscles. In management, elective or definitive management is going to be the chest tube insertion, while the emergency management is emergency thoracotomy. The indications for emergency thoracotomy are more than 1 or 1.5 liters of blood, then more than 200 ml of blood for more than or equal to 3 hours, and aortic injury, cardiac tamponade, or tracheobronchial injury. The chest tube insertion or ICD insertion, it is done in the triangle of safety. The posterior border is the axillary line, the anterior border is the anterior axillary line, and the base is formed by the fifth intercostal space, while the apex. So in that, the needle is inserted, the chest tube is inserted, it goes through the skin, subcutaneous tissue, then the serratus anterior muscle, 3 layers of intercostal muscle, then the parietal pleura. Digital exploration is done. Direction of the tube should be posterior to prevent the damage, and assessment of this ICD is done with the help of movement of water column. So water column is moving or not. Very important, air bubbles in the water column. This is not a functional assessment. Then chest tube removal. It should be removed when you ask the patient to inspire, and at the end of the peak inspiration, the chest tube should be removed so that there is no aspiration of air. Indications for removal are when the less than 100 cc is the output in 24 hours, and when the lung is distended again, and there are breath sounds that are being heard. Cardiac tamponade, it presents with a triad, and that is called as the Beck's triad. So Beck's triad, it is composed of hypotension, then muffled heart sounds, and raised JVP. The physiological amount of pericardial blood is about 10 to 50 ml. Minimum amount that is required is 60 to 70 ml to be diagnosed on first. Management of cardiac tamponade is always it's like a emergency hemothorax. So that is right anterior thoracotomy. So the left anterior thoracotomy is done along with evacuation of hematoma and pericardial drain. No role of pericardiocentesis in cardio tamponade. Just like we do in tension pneumothorax, where there was needle thoracocentesis, here there is no pericardiocentesis is done because blind procedure can lead to damage to the heart. Then traumatic thoracic aorta injury is similar to the aortic dissection. The most common site is distal to the ligamentum arteriosum. Then the clinical features, there is a difference in the BP in the two upper limbs, absent pulsation in the one limb. Then chest X-ray findings are widening of the mediastinum, and the left mainstem bronchus is found to be uh, depressed. Then the then the investigation of choice is stable. It is contrast and on CT and in CT angio, and in unstable patient there is trans esophageal echocardiography TEE. Management, again the same that is aortic dissections, selective beta blockers, that is esmolol, that leads to permissive hypotension, and then graft repair, open graft repair, endovascular graft repair. Sternal fractures, ECG monitoring needs to be done, and cardiac enzymes to be monitored because it increases the chances of myocardial infarction. Management is conservative. You don't need to go for any surgical intervention. Diaphragmatic fractures, it is more injury. It is more common in left side as compared to the right side because right side is protected by the liver. Penetrating trauma is associated with. The clinical features of diaphragmatic injury is breathlessness and bowel sounds that are heard in the thoracic region. Management, ICD insertion should not be done blindly because that can lead to perforation, and laparotomy should be done. Then neck trauma. Neck trauma, there are three zones. Now remember, these three zones, they are not like retroperitoneal trauma, they are upside down. So the zone 1 is actually from the thoracic inlet to the cricoid cartilage. Then the second is from the cricoid to the angle of mandible, and third is from angle of mandible to the base of skull. Maximum mortality is found in zone 1 because important structures are present. The management is angiography and embolization. Then in the second region, that is from cricoid to mandible, it is the most common accessible, most exposed region. Here conservative management, and then go for surgical intervention. And in the zone 3, it is from the angle of mandible to the base of skull. Angiography and embolization is done. Indications for intervention: neck trauma, subcutaneous emphysema, air bubbling through the open wounds, the expansile hematoma, and hoarseness of voice. So these are going to be all the indications. So this is all about the thoracic trauma. Then starting off with the head trauma, anatomy of the scalp region. So scalp, the mnemonic is scalp itself. S stands for the skin, then the C stands for the connective tissue. Now connective tissue over here is arranged in such a way that it consists of fibrous septa, and because of which the vessels cannot also constrict, and if there is a bleeding, it keeps on bleeding. So for that you have to apply the pressure over the scalp region, or suturing is needed. Then next is aponeurotic layer. Subaponeurotic bleeding can lead to black eye. Then there is going to be loose areolar tissue. The loose areolar tissue consists of the veins, that is emissary veins, that can lead to cavernous sinus thrombosis, and P is the periosteum. Then there are two types of skull fractures: non-depressed skull fracture, depressed skull fracture. In non-depressed skull fracture, conservative management is required. In depressed skull fracture, the surgical elevation is required. Indication is if there is focal neural deficits present, or if the thickness is more than that of the skull thickness. Then the base of skull fracture, that can be either anterior cranial fossa, middle cranial fossa, or posterior cranial fossa. The bone fracture in anterior cranial fossa is the cribriform plate. It is associated with raccoonized CSF, rhinorrhea, epistaxis, and osmia. For the middle cranial fossa is the petrous part of the temporal bone. The clinical features are the battle sign, CSF otorrhea, hemotympanum, seventh nerve injury, and paradoxical rhinorrhea. Rhinorrhea is in ACF, paradoxical rhinorrhea is in MCF. This is because of the eustachian tube. Then in the posterior cranial fossa, obviously the occipital lobe is involved, that will lead to visual problems. Then sixth nerve palsy and the Burnet syndrome, or it is also called jugular foramen syndrome, where 9 to 11 cranial nerves are affected. In management, you have to consider or treat it as an open fracture. Prophylactically, third generation cephalosporins are given to prevent meningitis, and don't pack the nostrils or the ears. Then there is a NICE guidelines. So NICE guidelines, first step is you have to rule out the cervical spine injury. The second step is GCS monitoring. So Glasgow Coma Scale monitoring should be done in 2-4 for every 2 hours, 4 hours, and 6 hours. For the first 2 hours, you have to do the monitoring for after every half an hour. For the next 4 hours, after every 1 hour, monitoring is required, and for the next 6 hours, after every 2 hours, the monitoring is required. Then, what are the indications for non-contrast CT? So indications for non-contrast CT in adults within 1 hour is GCS less than or equal to 13 at any time, GCS less than 15 at 1 hour, repeated vomiting, focal neurological deficits, loss of consciousness. If you suspect depressed fracture, open fracture, or base of skull fracture, then post-traumatic seizures. Within 8 hours, you have to go for NCCT if the age is more than 65. Retrograde amnesia is present for more than 30 minutes. In children, if the GCS is less than 15 at any time, seizures, base of skull fracture. What are the indications for calling upon neurosurgeon if the GCS is less than or equal to 8? Fall in the GCS after the admission, unexplained confusion for more than or equal to 4 hours, and rest all indications remain the same. Now talking about the brain injury, generally the isolated brain injury or the isolated head injury, it is not associated with hypotension. It is associated with hypertension if there is a frank bleeding or if there is a bleeding in concealed hemorrhages, for example pneumothorax, hemoperitoneum, spinal injury, or in late cases whenever there is a herniation of brain that is seen. Then the brain injury is divided into two: primary brain injury, secondary brain injury. Primary brain injury, it has further types, that is concussion and diffuse axonal injury. The concussion, the severity is more in diffuse axonal injury, it is less in concussion. Mechanism, concussion it is caused because of contact sports, while diffuse axonal injury is caused because of high velocity injuries. Then the clinical features, the grading that is done in concussion is the Colorado grading, and multiple concussions that can lead to chronic traumatic encephalopathy. Investigation of choice remains to be non-contrast CT in primary brain injury. In the secondary brain injury, it remains to be a MRI for diffuse axonal injury. In autopsy of the diffuse axonal injury, it will reveal a clubbed axons and retraction balls. Then talking about the contusion. Contusion is the most common type of intraparenchymal hemorrhage. The most common site of contusion is going to be temporal lobe followed by the frontal lobe. Investigation of choice again the non-contrast CT. Management, majority of management is conservative, and if there's an increased size of multiple contusions, they are coalescing with one another, then in that particular case we have to do surgical evacuation. Extradural hemorrhage is generally found in young high velocity injuries. Artery involved is the middle meningeal artery. Most common site is the pterion. The lucid interval, the space or the interval of consciousness between the two intervals of unconsciousness. Investigation of choice is NCCT. Management is either a burr hole or craniotomy. Generally craniotomy is preferred nowadays. The indications for craniotomy are if the clot size is more than 25 cc, if the clot thickness is more than 1.5 cm, more than 5 mm of midline shift, and GCS of less than or equal to 8. To decide the site of craniotomy, NCCT is done, or if it is not there, then it should be done on the side of mid-dilated pupil or dilated pupil. Normally, it is seen that if left hand EDH is present, right side the hemiparesis happens, that is contralateral. But if it happens on the ipsilateral side, then that phenomenon is called as Carnohan notch phenomena. Then the subdural hemorrhage. The subdural hemorrhage is also called as the pachymeningitis hemorrhagica interna. Then the types are acute, subacute, and chronic. Acute within 3 days, then 3 days to 3 weeks subacute, and chronic within chronic or more than 3 weeks. Then it is secondary trivial injury, generally found in elderly population. Initially they are normal, then leads to altered sensorium. The veins that are involved are the breaching veins. Management is again craniotomy. What are the indications for management? If any one of the following, that is if the clot thickness is more than 1 cm and more than 5 mm of the midline shift, or any two of these three, that is more than 2 point drop in GCS, ICP more than 20, and fixed dilated pupil. Then subarachnoid hemorrhage. The traumatic subarachnoid hemorrhage is the most common cause of subarachnoid hemorrhage, which is managed conservatively. Over here in the subdural hemorrhage, you will find this convex type of opicities. Then talking about the intracranial hemorrhage. Intracranial hemorrhage, the most common cause is going to be hypertension, and the most common site is going to be the putamen of the basal ganglia. And subarachnoid hemorrhage, most common cause is traumatic, which is managed conservatively, that we saw. Another cause can be rupture of Verey's aneurysm. The type of aneurysm is it is a junctional aneurysm and saccular aneurysm. The most common type of aneurysm overall is the Verey's aneurysm. The most common type of extracranial aneurysm, if someone asks, then that is going to be infrarenal abdominal aorta aneurysm. The risk factors for Verey's aneurysm, they are the polycystic kidney disease, Ehlers-Danlos syndrome, Marfan syndrome, fibromuscular dysplasia, smoking, hypertension. So these are all the risk factors. Then the clinical feature, it will have a thunderclap headache or the worst headache of life. Then Terson syndrome, that is subarachnoid hemorrhage along with Veter's hemorrhage. Middle cerebral artery aneurysm. The middle cerebral artery aneurysm will show with retroorbital pain. Then investigation, most common site in the circle of Willis, it is at a level junction of anterior cerebral artery with anterior communicating artery, or it is at the level of posterior cerebral artery and posterior communicating artery. The investigation of choice is the non-contrast CT, and over in here the grading that is done is called as the features grading. CSF tapping can also be done, that shows the anthochromia. This is yellowish color because of the RBC lysis. In the clinical grading, it is Hunt and Hayes grading and World Federation of Neurological Surgeons. Then management, the first step of management is the cerebral angiography, then go for interventional radiology, and then coiling and clipping. The complications of bleeding, hemorrhage, then the delayed ischemic neurological deficits. This is because of vasospasm secondary to interventional radiology, and for that prevention we go for nimodipine. Then talking about a secondary brain injury, the doctrine is called as the Monro-Kelly doctrine. So according to Monro-Kelly doctrine, the intracranial, even though the mass inside increases, the intracranial pressure usually remains normal, but till a certain capacity, because the skull is fixed. Otherwise, the brain is expansive in nature. So over here, this is given by this graph. At a point of decompensation, the intracranial pressure increases. When the intracranial pressure increases, then the cerebral perfusion pressure decreases. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. The cerebral perfusion pressure normally should be more than 60 mmHg. For that, the mean arterial pressure should be more than 80 to 90 mmHg, and the ICP should be less than 20 mmHg. But if the ICP rises, the Cushing's reflex is activated. So what is there in the Cushing's reflex? It leads to increased blood pressure, decreased heart rate, and altered respiration. The management is you have to avoid the dextrose solution over here, because that can lead to further cerebral edema. IV mannitol is given, and no role of steroids. Steroids are used only and only in vasogenic edema. Then nice discharge guidelines are when the GCS is 15/15, when the patient is under no influence of alcohol and drugs, NCCT is normal, and you have to discharge it with a adult. The Glasgow outcome score. Glasgow outcome score does it grading. Grade 1 is death. Grade 2 is a persistent vegetative state or coma. Grade 3 severe disability. Grade 4 is moderate disability. Grade 5 is mild disability. Then the next we'll talk about this, that is the brain herniation syndromes. The brain herniation syndromes, they are due to decompensation. After a certain decompensation point, the ICP just going to keep on increasing. So the first is uncal herniation, that is also called as the lateral transtentorial herniation, where the temporal lobe mass is seen. It is seen by a clinical feature, that is ipsilateral third nerve palsy, and contralateral hemiplegia, that is Weber syndrome type of features. Along with that, sometimes Carnot notch phenomena can be seen. Central or transtentorial herniation, that happens to the foramen magnum. Coma, bilateral meiosis is seen. Then the person goes into decorticate, then decerebrate rigidity, respiratory paralysis, and further death. Subfalcine herniation, it happens of the frontal lobe and the parietal lobe. It happens below the through the cingulate gyrus. Coma and contralateral weakness is seen. Posturing is seen, and anterior cerebral artery is most commonly damaged. Cerebellar herniation will lead to cerebellar signs, that is ataxia and all those. And apart from that, coma and bilateral posturing is also seen. So this is all about the brain herniation syndromes. Then the brain abscess. The brain abscess, it has about two modes of spread. Either it has hematogenous spread or direct spread. Hematogenous spread, it leads to parietal lobe spread, and the risk factor for it is immunocompromised patients or cyanotic heart disease patients. And direct spread, it is secondary to sinusitis, that is secondary to frontal sinusitis, leads to frontal abscess. Secondary to otitis media, it leads to temporal abscess. Investigation of choice in this case is the CT. Then the next are congenital malformations. In the congenital malformations, there is spina bifida occulta, where the tuft of hair is present. You have to manage it completely conservatively. Then the next is spina bifida aperta, wherein it is meningocele or myelomeningocele. In meningocele and myelomeningocele, there is a lower limb weakness, bowel bladder dysfunction, fluctuation and transillumination present. Investigation of choice to for the extent is going to be MRI. Now very important is you have to manage this surgically within 3 days until that sac is covered with a saline solution. Over here, one point I missed in the cerebral in the brain abscess is that this ring enhancement lesion can be seen on the CT. Then next is the Chiari malformation. So in the Arnold-Chiari malformation, it is type 1 and type 2. So in the Arnold-Chiari type 1, it is due to the downward displacement of the cerebellar tonsils. And the type 2, it is the downward displacement of cerebellum, brainstem, as well as the fourth ventricle. Type 1 is associated with syringomyelia, and type 2 is associated with hydrocephalus. The age of presentation for type 1 is young adults. Here in type 2 it is going to be the infants. Usual presentation for type 1 patients is going to be the neck or cervical pain in type 2 patients is going to be progressive hydrocephalus. Spinal bifida is present in type 1 patients, and management for type 1 is conservative. For type 2 it is management of hydrocephalus, ventricular peritoneal shunt repair and all, but generally it has got a poor prognosis. The next is the Dandy Walker malformation. Over here you can see the cystic dilation of the fourth ventricle, and the cerebellar worm hypogenesis or agenesis is seen. Investigation of choice is the MRI. This is because of foramen magenti and Luschka's problem. Then the next is CNS tumors. The most common brain tumor is the metastasis to the brain. Most common metastasis to the cerebrum, it is the lung metastasis, and the most common metastasis to the leptomeninges is the breast. Most common primary brain tumor is going to be the glioma greater than meningioma, and most common primary brain malignancy in children is going to be medulloblastoma. The frontal lobe is getting involved in visual shift syndrome is seen, that is pathological joking and personality changes are seen. Then the next investigation of choice is going to be MRI for the brain tumors. PET-CT does not has low sensitivity for it. Then radiotherapy, surgery, chemotherapy is given. Radiotherapy is of two types. Wide radiotherapy, whole brain is given, or stereotactic at a particular location it is given, localized one. Then solitary mets, we go for surgical removal. And the first individual cancers, the first is astrocytoma. It has grades. Grade 1 is pilocytic astrocytoma juvenile, grade 2 is low grade or fibrillary, grade 3 is anaplastic, grade 4 is glioblastoma multiforme, that is involving both the lobes. Now over here in the astrocytoma, juvenile pilocytic astrocytoma, the most common site is going to be the occipital lobe, and that is the posterior fossa, and here a mural nodule is seen that does not show any infiltration. In glioblastoma multiforme, here hemorrhage and necrosis, and it spreads across both the lobes. It is also called as a butterfly tumor. Management is again surgery, radiotherapy and all, and management is by oral temozolomide. Then oligodendroglioma. Oligodendroglioma is generally seen in 40 to 60-year-old population. For here you can see multiple calcification, that is called as intratumoral calcification. Then chicken wire blood vessels, fibrosis, calcification is seen. Ependymoma, it is seen in children. Then in the fourth ventricle it affects, then it shows a drop metastasis and hydrocephalus is seen. In ependymoma, along this artery or along this blood vessel, the rosettes can be seen, so perivascular pseudo-rosettes are seen. In meningioma, it is attached to the dura mater, so it is generally found in females at around 50-60 years of age. It is extraaxial and dural based. Here the dural tail sign is seen and samoma bodies are visible. Then medulloblastoma, hemorrhoid pseudo-rosettes are seen, right, with a pus positive stain in between. Now, medulloblastoma, as I said, it is the most common primary brain malignancy in children. The metastasis, it is a drop metastasis, and it is associated with Turcot syndrome, which is a variant of familial adenomatous polyposis. Then the CNS lymphoma is seen in immunocompromised patients, that is HIV and post-transplant patients. The type is a B-cell, diffuse large B-cell lymphoma. It's called as a ghost cell tumor. Why is it called as ghost cell tumor? Because it is steroid responsive in nature. Upon giving steroids to this patient, this tumor will disappear on the further MRI. So the investigation of choice remains to be the biopsy. And this is a tumor. This is a table about the pathophysiological features of different tumors. So pilocytic astrocytoma, rosenthal fibers and microcysts are seen. In glioblastoma multiforme, which is a type 4 astrocytoma, serpentine necrosis and glomeruloid bodies are seen. Oligodendroglioma, calcifications, chicken wire blood vessels, fried egg appearance. Ependymoma, perivascular pseudo-rosettes. Medulloblastoma, hemorrhoid pseudo-rosettes and small blue red cells are seen. Meningioma, samoma bodies and dural tail sign is seen. And in schwannoma, Antony A, Antony B and the verrucae bodies are seen. So this is all about the head tumor and neurosurgery aspect. Now moving on to the next and the last topic of this, that is the thermal injuries. So in the thermal injuries, the first is the referral criteria to the burns unit. So the referral criteria to the burns unit involves any burn that is involving the face, hands and the genitalia, chemical burn, electrical burn, lightning injuries, inhalational injury, or if the partial thickness burn is more than 10% of body surface area, or any kind of full thickness burns or third degree burns. Now when I talk about the airway burns, so in the airway you should look for the signs. For example, if there is an inhalational injury, then that will lead to cinching of the hairs. Then in the sputum there can be carbonaceous deposits. Voice, there can be hoarseness of voice. all the airway burns they require a prophylactic intubation because there is a rapid airway collapse. So if in the question, if it is said that if any of these three features are seen and you suspect an inhalational burn injury, then you have to give prophylactic intubation despite however stable the patient is. Now the stages of the airway burns, the first stage is the uh, hypoxia, then ARDS like picture for 1 to 2 days with bilateral lung infiltrates hypoxia, and then bronchopneumonia. So in the early phase, the bronchopneumonia for 1 to 3 days is caused because of Staph aureus, and the late is caused because of Pseudomonas. It is a gram-negative bacteria. Now during the breathing, you need to check for a shot around the chest. If there is a shot, then you have to go for a escherotomy. Then the circulation, you have to look for if the burns there is inflammatory mediators that are released, and these inflammatory mediators they lead to vasodilation. Because of vasodilation there are leaky vessels and abdomen, and albumin is lost that leads to tissue edema, that is third space loss. Similarly, these inflammatory vasodilators, if they are less than 10% of the body surface area, there is a localized response, but if they are more than 10% of body surface area, then it's a generalized immune response, which will again lead to dehydration in the patient. So to correct that, the fluid resuscitation is required. Colloids and crystalloids. Colloid resuscitation generally given after 12 to 14 hours. Otherwise, it will lead to further aggravated third space loss. So the colloid resuscitation is given by a formula that is called as Muir and Barclay formula. So Muir and Barclay formula is for albumin, hydroxyethyl starch and all. Then crystalloids, the most commonly used is the ringer lactate solution or the Hartmann solution. For this, there is a Parkland or modified Parkland's formula. Now modified Parkland formula, it is also called as the Brooks formula. So according to the Parkland formula, it is 4 into body weight in kg multiplied by the percentage of total body surface area that is burned. But according to the modified, it is 2 multiplied by the body weight in kg multiplied by the total percentage of the body surface area that is burned. So earlier it was 4, but now it is 2. So according to the modified burn resuscitation, if it is a flame or a scald, and for more than 14 years, less than 14 years, and infants, this table is very important. The fluid that we have to give is 2 ml multiplied by kg into percentage body surface area. Then for less than 40 years it is 3, and for infants again it is going to be 3. Very important, the urine output for more than 14 years is 0.5 ml per kg. Here it is 30 to 50 ml per hour, and for infants it is 1 ml per kg. But however, if it's a case of electrical injury, that is shock. So if this patient is of electrical injury, then in that case, the fluid resuscitation that is given is 4 into kg into percentage total body surface area. That is according to the old Parkland formula. This is very important. So electrical injury, more fluid resuscitation is required, and the urine output should also be 1 to 1.5 ml per kg per hour. Then the maintenance fluid that is given in children that we know is for the first 10 kg it is 100 ml per hour, for the next 10 kg it is 50 ml per hour, and then 20 ml per kg for the next 10 kgs. Also Galveston formula can also be used. Then for surface area calculation, there are zones of the burns. So the zones are given by Jackson. So there is zone 1, zone 2 and zone 3. Where the burn has happened, that is going to be the zone of coagulation or necrosis. Then surrounding that there will be a zone of stasis, and then surrounding that there is a hyperemic zone. Now for surface area calculation, we have the palm surface area, then Wallace rule of 9, but the most specific is London Prodder's classification. Now next is the degree of burns. So in the degree of burns, this is very important. First degree of burn, where there is a redness, tender, blanching is present and scarring is absent. Example is going to be the sunburn. Then second degree burn is where it is further divided into superficial and deep. In superficial, epidermis and papillary dermis is involved, while in deep burns it is epidermis plus the complete dermis. In superficial burns it will lead to blisters formation, scarring is absent, and the composition of this is, as I said, it consists of epidermis and papillary dermis. Now in the deep burns, again epidermis and full dermis, and the scarring is present over here. And in the third degree burns, it involves the subcutaneous tissue, and fourth degree burns, it involves the muscles. There is a blackening, complete shard, blanching is absent, then pain is also absent. So pain is relatively less in second degree deep burns, but it is completely absent in third degree and fourth degree burns because the nerve endings are damaged. Management is going to be early excision and split thickness skin grafting. Then rise tube insertion. The rise tube insertion should be done in about 50 to 20% of the burns cases to avoid vomiting caused by ileus. Then avoid the blister bursting. Similarly, you have to avoid the intramuscular and subcutaneous injection. Now, compartment syndrome can occur. Compartment syndrome, the pressure is more than 30 mmHg. Now, it is due to circumferential pressure from all the sides that will lead to increased pressure. And the management of compartment syndrome is obviously ischiotomy, which is a type of ischiotomy in this particular case. Then, talking about the caloric requirement. So, the caloric requirement and the protein requirement formula. For the calorie C for C, the caloric requirement formula is Curry and Sutherland formula. For protein requirement is the Davies formula. Protein is required from day 5 to day 10. Then basal energy expenditure is about 2 kilocalories per kg, which is normal. But however, in case of burns, it is 40 kilocalories per kg per day, that is twice the normal. Then the next is dressing material. So in the first degree burns, to expose the wound. For this second degree burns, for superficial burns, Vaseline or paraffin gauze is applied or collagen dressing is applied. Now this is again so second degree superficial burn, the example is scald injury. So scald injury also we go for collagen dressing or Vaseline or paraffin gauze dressing. For second degree deep burns, hydrocolloid dressing is done, that is duoderm. Then there are some special agents. They are the silver sulfadiazine, which is the most common cream. The advantage of it is that it is effective against the pseudomonas. The disadvantage being we need to frequently change the dressing and doesn't penetrate the scar. Then the silver nitrate, again the same advantage, but disadvantage is black staining. Then 5% mafenamide acetate, it penetrates the scar, but however it is painful in application and metabolic acidosis can precipitate. The best cream overall is going to be cesium nitrate. The only disadvantage is it's expensive in nature, otherwise advantage also acts as an immunomodulator. Then the causes of death. The most common cause of immediate death following burns is going to be asphyxia because of carbon monoxide. Then in early, that is within 3 days, there is a hypovolemic shock, and late after 3 days, the most common cause of death is going to be septic shock, and the most common causative organism is obviously going to be pseudomonas. Now there are some special types of burns, that is the chemical burns. Chemical burns you have to wash with water, and the water should not be very cold water as well as not very hot water. It should be at the room temperature. Maximum temperature can be 25 degrees Celsius. Don't try neutralization of either burns. For example, if it's alkali burn, don't pour acid or vice versa. Then hydrofluoric acid burns, it presents with hypocalcemia, hyperkalemia because of the muscle lysis, and acidosis. So it's hypocalcemia occurs because of chelation. So in that particular case, the treatment is IV calcium gluconate. Then electrical burns, as we know, the fluid resuscitation required is more. It's almost a 3rd degree or 4th degree burn always. It can be a DC burn or AC burn. So DC current, it leads to heart block, while the AC current, it can lead to tetany, which is the most common, but however the most common cause of death is the arrhythmia. Then lightning injury can be direct injury or it can be an indirect injury. Direct injury is a high grade injury and it can lead to arrhythmias. Indirect injury, it leads to filigree burns, crocodile burns, or superficial burns. Next is hypothermia. Hypothermia is caused when more than 30 minutes of cold exposure is there. This place to measure the body core temperature is the rectum and followed by the esophagus. Now there are different stages of hypothermia, stage 1, 2, 3, 4. In the stage 1, there is a patient is conscious, shivering is present. The body temperature is 30 to 35 degrees Celsius, and over here passive reforming should be done. In stage 2, there is impaired consciousness of the patient, shivering is not present. On the ECG, you can see the J waves or the Osborn waves. The temperature is 28 to 32 degrees Celsius, core body temperature. For here, active reforming is required. Immobilize the patient, and there is a risk of arrhythmia. Then in class 3, there is the patient becomes completely unconscious, but however the vitals are present. So it is 24 to 28 degrees Celsius. Here you need to do CPB plus extracorporeal membrane oxygen. Class 4 patient, stage 4 patient, there are no vital signs only, less than 24, so you can give cardiopulmonary bypass, CPR and extracorporeal membrane oxygen. Then there are conditions like the heats, frostbite and trench foot. Frostbite is caused because of dry cold exposure that will lead to the formation of ice crystals, so that is very painful in nature and further gangrene. Trench foot is the immersion of foot, and it is actually wet cold injury, and this leads to microvascular damage. And I think the same thing. Management is rapid reburning is required up to 40 degrees Celsius. Then some heat related conditions like heat syncope or heat exhaustion, which is generally found in the schools. Right here, the body temperature is maintained, it is less than 40.5 degrees Celsius. Thermoregulatory center is completely normal, sweating is present. In heat stroke, the sweating is absent, the thermoregulatory center is gone, the body temperature is more than 41 degrees Celsius, right, and it's difficult to manage this patient. Then it heat cramps. In heat cramps, is decreased levels of sodium, then potassium as well as water inside the body. So salts and water in the body decreases, that will lead to heat cramps, generally found in the minors, and there is involuntary spasmodic contractions. Heat edema. Heat edema can be seen normally because of the exposure to the heat. What happens is cutaneous vasodilation, and because of which um, the exudates they go out, and that will lead to edema. So this is all about the thermal injuries as well.